Good morning, everyone. My name is Adil Alwan. I'm a nephrology resident at Salmani Medical Complex, Bahrain. Today I'm going to talk about the quality of life among renal transplant recipients in Bahrain. Our study was done in collaboration between the College of Medicine, Arabian Gulf University, and Nephrology Department at Salmani Medical Complex. This is a picture of our center. This is part of our team. Renal transplantation has a vital impact on the lives of patients with end-stage renal disease. Not only does it promote both short-term and long-term physical well-being of our patients, it also has an impact on the psychological, social, and spiritual well-being. Despite the growing number of end-stage renal disease patients in Bahrain and having a well-established renal transplant program, we still have a shortage of quality life studies in renal transplant recipients in particular. The aim of our study was to study and assess the quality of life for renal transplant recipients in Bahrain and the effects of the different socio-demographic and clinical variables on their quality of life. We conducted this study at the nephrology outpatient clinics in Salmani Medical Complex over a 5-month period. We used the standard quality of life index score instrument in both the Arabic and English languages. We included 58 patients aged 26 to 71 years. We included all the renal transplant patients following up at our clinics aged 18 or older. We excluded those who were on dialysis at the time or had failed renal transplant. We excluded any patient who were having any cognitive or physical disabilities that interfered with their ability to answer the questionnaire. This is a picture of the questionnaire that we use, the Quality of Life Index, designed originally by Friends and Powers in 1985. The questionnaire assessed the quality of life in 4 main domains: the psychological and spiritual domain, the family domain, the health and functioning domain, as well as the social and economic domain. Our results showed that the majority of our patients had an age between the 41 and 55. The majority were males. Most of our patients had a university graduate or higher. Most of them were married. Actually, 82% were married. Regarding the employment status, most of them were either a student, retired, or unemployed. Most of the income was below 400 Bahraini dinars per month, which is equivalent to below $1,000 per month. Most of them were living in towns or cities, and the majority had their renal transplant within the last 9 years. The primary source of the transplanted kidney was living unrelated donor, and most of the transplants were done outside Bahrain. The duration of dialysis before transplantation was relatively short. It was the majority had around 1 to 3 years of dialysis before transplantation. Most of them had comorbidities, with diabetes and hypertension being the 2 main comorbidities identified. We calculated the mean scores for the quality of life. The overall quality of life had a mean score of 83.8, which is a moderate quality of life. The highest score were in the psychological and spiritual domain, which had a moderate score across all the items, with a high score identified in the faith in God category. The family domain had also moderate scores, but a low score identified in the sexual life of our patients. We think that this is due to our patients having multiple comorbidities, including diabetes mellitus, which also affected the sexual life. Regarding the health and functioning domain, it had a mixed picture of scores, high and low. There is a high score in the satisfaction with the transplanted kidney, and there is low scores in the amount of pain, the amount of energy available for daily activities, and the ability to take care of financial needs. Regarding the social domain, it had the lowest scores overall, with low scores in particular in the amount of worries in life and not having a job. This is another representation of the scores. Overall, the quality of life had mostly moderate scores. The psychological spiritual domain had equal distribution between high and moderate scores, and the rest had moderate scores. Regarding the association, we found that married participants had significantly greater quality of life scores in the health and functioning domain compared to unmarried participants. This was also the case in the family domain. We think this is because the married participants had an extra support, both socially and financially, from their spouses and children. The health and functioning domain scores were also significantly greater in patients living in urban areas compared to those living in rural areas. This is because patients living in cities and towns had easy access to secondary and tertiary healthcare facilities. The quality of life index scores overall were significantly higher among patients who did their transplants in Bahrain compared to those who did it overseas. This is because the patients who did it overseas, they underwent commercial renal transplantation, which is from the literature associated with higher risk of early surgical complications and infectious non-surgical complications. The health and functioning domain was also significantly higher in patients without diabetes mellitus compared to those with diabetes. There is no significant association between the quality of life index and each of the following variables from our study: age, gender, educational level, monthly income, and employment status. I'm going to talk in particular about the association between the source of the transplant kidney and the quality of life. In our study, we didn't find any significant association. This is in line with recent studies that even showed that the graft survival rate is not significantly different between living-related and living-unrelated donors. Regarding the total duration of dialysis, we didn't even find association. This is because I think our sample had relatively short duration of dialysis. We need future studies to have longer follow-up and larger sample to further evaluate this association. In general, we studied the inter-domain correlation and association between the quality of life and its domains, and we found that that's very highly statistically significant, and there is high positive to very high positive correlation between them. The limitation for our study included a relatively small sample size. We need in the future to include more clinical and laboratory parameters that might influence the quality of life. There is also need to include control groups like healthy individuals or hemodialysis patients to go for head-to-head comparison in the quality of life. In conclusion, our main study is to find a comprehensive understanding of the quality of life in renal transplant recipients in Bahrain, as well as the different factors that are associated with it. We aim that we form a multi-targeted healthcare plan that not only address the physical aspect of the patients, but the social and psychological aspects, with working side to side with the other healthcare sectors. Thank you for listening.